Now I requested Dr. Sanjith Saseedharan to come for presentation. Dr. Sanjith Saseedharan is very well renowned for his astounding clinical skills, knowledge and experience, which has made him one of the most sought after intensivists. He has trained in 3 continents and has 103 articles in peer-reviewed journals, written 2 books as single author, 12 textbook chapters, 8 research paper awards, 1 copyrighted protocol in his name, and 2 softwares in critical care. He is also a teacher and has trained many doctors in the art of critical care. He is presently the President of the Indian Society for Parenteral and Enteral Nutrition and has received the IA Modi Award for Clinician of the Year 2023. Dr. Sanjith presently heads the Department of Critical Care at the SL Rise Hospital and is responsible for making it the finest in the country. He can be reached at 9004.
Thank you very much. And the merits of any conference depends on the science of this conference has been spot on, and kudos to the organizers for that. Can I have my PowerPoint song? Right. So nutrition research is very, very messy in the first place, and it's something that is problematic, has been problematic all through the time. But there's been a huge buzz in critical care nutrition in the last couple of years. In fact, there's been a huge number of explosion of papers that have come out in the last couple of years, and that is actually related to a large number of guidelines. I mean, guidelines have come in the last couple of years only, which has actually given us a direction in nutrition. But it's very important to know that there is huge conflicts in the trial data and the guidelines that come. There's a huge number of conflict in the trial data and the conflicts that is there. And that's basically made evidence-based practice to become very murky. In fact, translation of evidence into practice has become very, very difficult. In fact, there are a large number of burning topics that are there in literature which are not really answered by trials in nutrition. And in fact, one of the biggest things that basically is problematic is this. Literally, it's burns nutrition which is still burning. And in fact, we've been learning for the last couple of years, many years till now, that the way to get around burns is to actually have enteral glutamine. And this is there and ingrained in the philosophy of nutrition that enteral glutamine can be used only in 1 class of patients, and that's more than 20% burns, and that's the guideline that it says. That's the dose that's supposed to be given, enteral glutamine. Well, this came out because, in fact, there were a number of trials, and one of these trials is this one, which actually started the whole ballgame, 120 patients in East Africa and Kenyatta Hospital, where they actually gave enteral glutamine versus normal nutrition. And what they found was that those patients who received enteral glutamine, they actually had reduction in pus swab cultures. Positive swab cultures were much lesser in those patients who basically had glutamine. Well, we all know that burns kills because of infection, and when you get down an infection, we probably may do something good. But if you thought these are just pus swab cultures, it's important to know even bacteremia actually came down. In fact, even those patients that received glutamine, they had a much lower amount of bacteremia. Now, consequent to this trial, there were a number of randomized controlled trials that came out, 4 or 5 of them, which were actually grouped together into meta-analysis. So 4 or 5 years later, another meta-analysis came with all these RCTs put together, and they found similar data. They found data that said it reduced gram-negative bacteremia and it reduced hospital mortality, and that's the reason, that's the precise reason that guidelines kept shouting out to all of us that we need to actually give glutamine to burns patients. Well, surprise. This 6 months ago, 8 months ago, there was a trial that came out with actually, not a trial actually, a reviewed trial sequential meta-analysis which actually said that there is absolutely no difference in mortality. Absolutely no difference in mortality, absolutely no difference in gram-negative infections, debunking all that we have done for so many years. But let's look very carefully at these trials. Why were we doing this for so many years? Why were we in these guidelines for this? This actually intrigued me. So what we did is they actually removed all these trials, first of all. When you remove these trials that were there, and what I put over there are single-center trials. When you put single-center trials over there, we find that the overall mortality changes and it's beneficial. Needless to say, it was beneficial. But the moment we add the multi-center trials, we find out that there is no effect. In short, what it does say is that when you actually do multi-center trials, it actually gives you the right answer is what it appears. And that's why I believe an analysis, systematic analysis or a review is not something that is good, not better than a very well conducted randomized controlled trial. And the next trial that is there is the most important trial that I put up. This is a randomized controlled trial done in 14 countries, 54 burn units, 1,200 odd patients done by Darren Hill, beautiful investigator. And what did he do here? He looked at intervention of 0.5 gram per kilogram per day of enteral glutamine versus placebo maltodextrin. This is what they did. And they did it for a really long time. They did it for the time till 7 days post last skin grafting procedure. That means they didn't just do it for 4 or 5 days. They did it for a long time. And discharged to the acute care unit 3 months after admission. And what did they look at? They looked at very important outcomes. The important outcomes time to discharge alive and a 6-month mortality. I think it's a very well conducted trial, well matched and done very beautifully. And what did they find? They found this. They found that there was no difference in 6-month mortality. There was absolutely no difference in 6-month mortality. You give glutamine, you don't give glutamine, doesn't make any difference. And that's the reason that glutamine supplementation now at this particular moment in adult patients is not associated with reduction in mortality or any other clinically relevant outcomes. So I think this trial seals the fact that in birth nutrition anymore we probably may not use glutamine, and in fact I don't see a reason to use glutamine anywhere in critical ill as of now. Well, the other thing that we always talk about whenever we enter into intensive care is we should feed the protein, we should feed them proteins, and we should give high proteins, and higher the better is what we always felt. We always felt that higher the proteins, better is what it is. So then comes this third trial, the third protein trial, very important trial, again by Professor Darren Hill. And what they looked was, again, 1,329 patients from 85 ICU, 16 countries, again multi-center large trials, where they looked at 2.2 grams per kilogram versus 1.2 grams per kilogram of protein for 28 days, again given for a long period of time. Now, they actually looked at 2.2, which you might think is alarming. Why they did that was because when they actually did the trial, the difference was 1.6 versus 0.9. This is what the difference was when they actually conducted the trial, because we know that 50% underfeeding iatrogenically occurs in most of our intensive care units, and they maintained the kilocalories to be normal. The kilocalories are actually normal, and this is the difference between the proteins. So we have a clear trial that actually tells us that, and then what did they look at? They looked at the primary efficacy endpoint, which is discharge alive by 60 days. It was not statistically different. That means you feed them less proteins, it really doesn't make a difference is what it looks like. In fact, 60-day mortality was also not statistically different. In fact, there was no difference in anything. Let it be duration of hospital, mortality, mechanical ventilation, ICU length of stay, nothing changed. So what does it mean? High protein does nothing. This is what it means. It says high protein in the intensive care unit really does nothing, and in fact, if you look at the sub-analysis of those, worsen outcomes for patients with AKI and greater severity of illness is what is seen. Eye-opener, I think it's very big eye-opener. This paper is very big eye-opener, I felt. And another thing that we always thought, now since proteins are high, what if I keep the calories in a different way? So this is the guideline. This present guideline says you start feeding in 70% of the energy expenditure, and when you reach day 3, you start getting to 80 to 100%. This is what the entire recommendation is all about. And this basic tenet was actually questioned by a very important journal trial, which actually came up recently from the CLICS investigator group. They looked at 3,000 patients, 61 French ICUs, a large trial. 6 calories versus the standard 25 kilocalories per kilogram per day, 0.2, 0.4 gram per kilogram per day of protein versus 1 to 1.3 gram per kilogram per day. That means they are questioning the standard of care. This is what they did. And they again looked at very good endpoints. The endpoints were time to adherence to discharge and 90-day all-cause mortality. This is what they looked at. And surprise, it's superb. So time to adherence to ICU discharge was in fact lower in those groups that were fed less proteins and less calories. In fact, even the time on invasive mechanism was reduced by 1 day. This is a big improvement that we have basically seen over here. And there was absolutely no, in fact, it was not good if you fed them high, because they had vomiting, diarrhea, constipation, and bowel ischemia, acute colonic pseudo obstruction. All of these were higher in those patients in whom we fed the higher standard of care. This means calorie and protein restriction was superior to standard calorie and protein intake for the first 7 days. So now what do you do now? We completely turned the entire clock upside down. So what we do now here is probably start early at a very low dose of 6 kilocalories per kilogram per day in intensive care patients whose Pachis scores are very high or reasonably sick. At very low doses of protein, at say 0.4 gram per kilogram per day, and you'll be surprised if you go back and actually look at your target proteins, whether you're receiving them, you'll be probably at this for the first 7 days. For the first 3 days. And if you have IC At day 3, probably do an indirect calorimetry and individualize the next requirements. I think this is probably the most scientific way to do this. And look for GI upset, reduce feed still tolerance for the next 3 to 4 days. I think this is probably the way we should do it. That means we presently don't have the sweet spot really easily. If you want to catch the sweet spot, where are going to be? Is the calories low, high? What do we do? So for that, let's go to one diagram. Okay, let's look at this. So on the y-axis, you have potential benefits. On the x-axis, you have the spectrum of disease severity across illness. And I always believe that nutrition will not work unless the spectrum of illness is right. So it doesn't work if it's very severe, it doesn't work if it's very mild, and we need to catch that for a place where probably aggressive nutrition will work. So let's look at a couple of trials. Okay, so we have the Python trial. The Python trial was done in pancreatitis patients, and they were admitted to the wards, and they received aggressive nutrition. It didn't make a difference. Alright? Then came the panic, cardiovascular thoracic surgery patients marginally, and hardly any difference was seen with there too. Then came the Nutria, which we just now discussed. We found that if they were severely sick and we gave them aggressive nutrition, they didn't do well. It was very clear. And that's why this particular trial, which is called the Swiss effort trial, was actually captured the sweet spot where what happened was those patients who were at risk for malnutrition, who are not severely ill, nor were they mildly ill, the moderate category of patients, that is where aggressive nutrition made a difference, and that's where mortality changed. The Swiss effort trial is something that all of us sitting in this hall should look at, because I think that's the point where we should do aggressive nutrition. Now let's go the other way around and look at, if you're not doing aggressive nutrition, will it cause harm? Well, we know. Let's look at this now. So what you see on the x-axis is percentage of calorie delivered, which are the proteins delivered. Okay. When you don't feed them, the risks are very, very high. So definitely we can't starve. That is definite. We can't starve. And we know from Eden Omega that if you feed them even profit feeds, it does less harm. That is very clear from the Eden trial. And from Nutria we know that if you feed them aggressively, there is too much harm. And that's the reason that we have to weigh the benefits versus the risks and feed them less than otherwise. Well, till now we felt that just feeding them with physiotherapy was the answer to improve physical function and muscle strength in our medical ICU, and we didn't have anything more than that. Remember this, our patients of intensive care, when they go back home, they are not even able to lift up their child and walk with them. That's the situation that they go home at. They're not able to complete a 6-minute walk test. 50% of them come back to the ICU for the next 6 months, and 70% of them actually die. So that's the severely ill situation. And why that occurs is because we really don't manage to get them functionally able, we don't get them to a condition where they can actually go home and live a normal life. So the answer to that is whether we could alter a little bit things in their diet. So this is a beautiful trial which actually looked at effect of multi-level intervention of resistance training with or without beta-hydroxybutyrate, beta-glutarate, HMB in medical ICU patients during entire hospitalization. Beautiful trial, 1:1:1 ratio using a computer-generated random sequence, which is non-linear of course. They had 870 patients. I'm going to take you through this trial because it's a beautiful trial. It's 870 patients were screened. They looked at 112 that were randomized. And they were randomized to 4 arms. The first arm was the one that received resistance training. When I say resistance training means they use TheraBands, they use bench presses, they use various kinds of equipment in the ICU which is against resistance so that they could exercise, and this is done for a while. And the second group received only HMB. They didn't get any resistance training, but they received HMB as a supplement. Then there was a combined category where they had resistance training and HMB together, and the last one was the placebo group, the control. And this was the control. And what they look at, very great endpoints I felt, and I think this is the way endpoints should be looked at in nutrition. They looked at short physical performance battery, 6-minute walk test, grip strength, body composition, all things that will get home, take the patient home and make him live a normal life. They did not find any significant changes in body composition. That means the muscle did not gain size in any of the groups. Nothing happened that way. The quality didn't change. Muscle scans were done and quality didn't change of the muscle. But when you looked at the graph, they found out that when you do resistance training with or without an HMB supplementation, it can enhance physical function. This means to say this is a very important marker. Physical function is a very important marker. It is something that will change the way the quality of this person would relate. And I think that's the key to all these things. If you see very clearly, resistance training and combination groups are the ones where the hand grip strength came up, the MRC scores were better, clearly indicating that this may be one of those miracle markers or miracle group of drugs that might help to get patients better. Right? HME is phenomenal drug, I feel. What about this drug, creatinine? Creatinine is something that comes from diet and can be made in the liver. It's something that gets into the muscle and gets the muscle stronger. Let me just tell you something about physiology, okay? When you're aging or acute critical illness, what really occurs is bioenergetic failure. When there's bioenergetic failure, the next thing that happens is muscle atrophy. Muscle atrophy causes functional disability, and that is what causes the morbidity. So if by any chance we could actually alter bioenergetic failure, we probably muscle atrophy, maybe we could probably help to reduce morbidity, is what it appears. Well, the answer may be methyl guanidine acetic acid. Probably is the answer. This is an ergogenic nutritional dietary supplement which we all know is called as creatine. This is creatine. Creatine is an ergogenic drug which will probably reduce morbidity, is what I feel, first in intensive care unit. And I want to show you this meta-analysis which actually looked at body composition, physical functioning and muscle function. They used creatinine in these, and this paper just came out 2 weeks ago. It's a beautiful paper that actually looked at these factors, of which muscle function is very important, I felt. We looked at muscle function. Clearly, bench press strength improved. Clearly, hand grip strength improved. Leg press didn't improve. Probably we exercise more of the upper bodies but not the lower. And that's probably the reason the bench press and the hand grip strength improved when you did something like this. Gave them creatinine. Let's look at body composition. Clearly, you see the lean body mass getting better. Clearly, that's very clear. Lean body mass gets better the moment you give the patients creatinine. And when you look at physical function, I'm going to show you this graph. It's a beautiful graph. It actually says that 30 seconds sit to stand up test. 30 seconds sit to stand up test actually improves. If you, how many patients of yours can sit on a chair and get up immediately or get up 5 times in 30 seconds? Very less. Almost impossible. None of them. So it clearly improves, and I find this 30 seconds sit to stand test should be the marker that we should look at when we look at nutrition, because it's a fantastic pliometric test. It is very easy of administration and no need for expensive equipment. Clearly proven that this should be the way we should look at critical care nutrition. It is a high intensity, explosive, short-term task, and it is central to ensuring functional independence. So it does look like we have got 3 important tools now in our basket that can help improve morbidity, and that's HMB, arginine, and creatinine. But what we see over here, I always felt which of these patients would do well if they were admitted to the intensive care unit. I always felt that obesity is a problem. I felt that it reduces overall life expectancy, it results in chronic inflammation and chronic disease. COVID has taught us that if you have obesity and COVID, the mortality is higher. I always felt that being fat is bad in sepsis. Felt that being fat is bad in sepsis, still this paper came out. And this paper is very important when you look at what's called the obesity paradox, where they looked at 7,000 odd patients for sepsis. And they were very well matched, all kinds of diseases, all kinds of sites of infection that was there, matched controls. And what they found was that obese people actually survive more, clearly survive more. Obese people seem to survive more if they have sepsis. And importantly, they also seem to have a better functional outcome. In fact, the length of stay in the ICU, discharge, CFS, and fertility all have better markers when it comes to obesity. I think what we've done is we've gone through a whole lot of literature, and what you see over here is the best literature across in recent times, and I think we are now getting to better research in nutrition. Thank you very much for your patience here.
Thank you, sir, for your presentation. Good analytical and evidence-based, which is very good in guiding intensivists in the early and moderate to sick patients with the low calorie and protein diet. So, any questions?